Thank you for joining us. My name is Audrey Hassan, patient liaison for the MDS Foundation, and I'll be moderating the presentation today. Thank you to Acceleron, Bristol Myers Squibb, Gamida, Jazz, Novartis, and Takeda for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Erica Warlick. Dr. Warlick was previously an assistant professor of medicine in the Division of Hematology, Oncology, and Transplantation at the University of Minnesota. Her clinical and research efforts focused on the treatment of hematologic malignancies, with a particular interest in myeloid malignancies and the development of new strategies utilizing hematopoietic stem cell transplantation, traditional chemotherapeutics, as well as novel biologic modifiers to treat this diverse group of diseases. She has now transitioned to a position in industry at Syros, a pharmaceutical company headquartered in Cambridge, Massachusetts. At Syros, she'll be working on the development of an oral arsenic compound for the treatment of acute promyelocytic leukemia. With that said, it is my pleasure to introduce Dr. Warlick.
So hello, my name is Erica Warlick, and I have the privilege of talking with you today about myelodysplastic syndromes. And specifically, we're going to talk about higher risk MDS and look at outcomes for patients undergoing stem cell transplant versus non-transplant modalities. In order to best understand MDS, I think it's important to understand kind of normal blood cell production. Then we'll move on to review the basics of myelodysplastic syndromes, really focusing on that higher risk subset. And then we'll talk about treatment strategies, hypomethylating agents, stem cell transplant, and potentially some clinical trials. So when we think about MDS, we have to step back and think about, well, what is MDS? It's usually low blood counts. So in order to think about why blood counts would be low, we kind of need to understand what blood cell production looks like. And a fancy term, or the scientific term for blood cell production, is hematopoiesis. So in order to have normal blood counts, the blood cell factory, or the bone marrow, needs to be working correctly. And this requires basically an assembly line balance. And if you think about blood cell production like an assembly line, that's a really good framework to think about it. So basically, cells start in the bone marrow, and they're very primitive or early stem cells. And those stem cells have to differentiate or grow up, and then they start multiplying and becoming more committed cells that do specific things like make our blood clot, make us stop bleeding, or fight infection. And here's a fancier look, or a deeper look, at what this bone marrow factory looks like. So we all have these things in our bone marrow called hematopoietic stem cells. And these are basically the mother of every blood cell in our body and every immune cell in our body. And there are really two lines of production. There's this lymphoid line and this myeloid line. And the lymphoid line is really important. This is the line that makes the lymphocytes that hang out in our lymph nodes. These are the cells that actually help respond to vaccines, like the COVID vaccine, to make antibodies along with these cells called the plasma cells. And if you get a problem on this side of the factory, it can be called lymphoma or multiple myeloma if it's a cancer of this plasma cell. This part of the factory is really working pretty well in MDS. It's this side that doesn't work so well, this myeloid side. And this side is really important. It makes the cells that make platelets that keep us from bleeding. It makes these cells called erythrocytes, or red blood cells, that carry oxygen to the rest of our body. And if these are low, you're considered anemic. It makes these things called myeloblasts that are really early white blood cells that then grow up into all the good infection-fighting white cells, specifically these neutrophils, which are really important first line of defense against infection. And so this is the side that is altered in MDS. And often what can happen is that you get a little roadblock here that keeps that myeloblast from growing up into the good infection-fighting cells. And when that roadblock happens, these myeloblasts start accumulating, and we get too many of them. And then it can crowd out the rest of the blood cell production in the bone marrow. So what is MDS? It actually is a really variable and complex group of bone marrow stem cell cancers with a very wide range of clinical severity. And the hallmark features of MDS are that the cells are dysplastic or funny looking. Patients often have low blood counts. Because they have low neutrophil counts, there's an increased risk of infection. And depending on the subtype of MDS, there's a varying degree of risk for transforming to acute leukemia or AML. So how does it develop? This is kind of my picture of what is going on in the bone marrow and MDS. So we have those stem cells that I showed you. And really, there ends up being some genetic event or some chromosome damage within those stem cells. There may be this thing called epigenetic modulation, and we'll talk about that a little bit in the future. And then there's just a lot of inflammation in the bone marrow. So this leads to a system or a setup for lower risk MDS, where we have a ton of production in that bone marrow. The bone marrow is trying to keep up, but the cells are dying off before they're supposed to, and they don't grow up how they're supposed to. So in lower risk MDS, you end up having a crowded bone marrow, packed of cells, but then they don't work right and they die off before they're supposed to. So then you have low blood counts. In higher risk MDS, which is what we're focusing more on today, you have a lot of that bone marrow cell growth, but then the cells stop dying off like they're supposed to. And again, they don't grow up. And this is where we can start to see more progression to acute leukemia. So back to that fancier picture of the stem cell, here's where the genetic event and epigenetic modulation happens. So who gets MDS? If we look at the SEER incident rates in the United States from 2014 to 2018, and just to orient you to the slide here, on this part of the figure, it's rates per 100,000. And on the bottom is age at diagnosis. And you can see MDS is not a cancer of the young. It really doesn't start to pick up until ages 50, mid-50s to mid-60s. Male are here in green and female are here in blue. And as you can see, really around age 60 to age 70, that's when you start to see maybe close to 20 cases per 100,000. So really not that common. And if you look at how many patients or how many people with MDS are in the United States at any one given time, a snapshot in January 1st of 2018 looked at how prevalent it is. And that just means how many active people alive with MDS are in the United States. And at that point, there were about 60,000 people living with MDS. So again, not that common. So why does it happen? For the majority of cases, we have no idea. That's called idiopathic or de novo. We just don't know why it happens. Something happens in that bone marrow that leads to this process. But there are cases that are secondary, and we describe that as being linked to an exposure. And this can account for about 20 to 30% of cases of MDS. And the top getters, or the most common things that can be secondary causes for MDS, are chemotherapy for other types of cancers, radiation therapy, or benzene exposure. Viral infections, alcohol, tobacco, immunosuppressive therapies are possible reasons. So of those folks who have had chemo or radiation, there are kind of two categories. People can develop it early, and this is 1 to 3 years after chemotherapy. And this is usually associated with specific chemotherapy drugs used for breast cancer chemotherapy or lymphoma therapy. And it's associated with a chromosome change called 11q23. There's a later onset form that happens about 5 to 7 years after therapy. And this is a little bit more common in radiation therapy or other chemo drugs that are used for lymphoma. And this is associated with a chromosome change of loss of chromosome 5 or 7. And we'll get into kind of how these chromosome components fit in with MDS in a couple slides. So clinically, what does it look like? Well, the clinical symptoms are really related to low blood counts. So anemia or low red cells leads to fatigue, being pale, shortness of breath, weakness, getting dizzy when you stand up. Thrombocytopenia or low platelets leads to increased bruising or bleeding. And neutropenia, which is low counts of those neutrophil cells, low infection-fighting white cells, leads to increased infections. So how do we decide, or how do we treat it? And how do we decide which treatment approach is the best? And this is when we really look at what patient treatment goals are. And we also use a number of MDS classification and prognostic scoring systems to help categorize the MDS. So in terms of patient treatment goals, some patients want supportive care only. So transfusions if the red cells or platelets are low, growth factors to boost up white cells in the setting of infections, but really minimal medical interventions. Then there's disease-modifying treatments, where the treatments may change the natural history of MDS, but don't cure it, don't make it stay away forever, but try to control it. And then there's potentially curative therapy or a stem cell transplant. So let's talk a little bit about these classification systems. The first one is the pathology classification system, or the WHO system. And this is the system that pathologists use when they look at your bone marrow biopsy to give the name to your MDS, or the subtype name to your MDS. And this is what it looks like. It's kind of a busy slide, but basically MDS is not one type of bone marrow cancer. It is many different types of bone marrow cancers, ranging from MDS with just one type of cell that looks funny versus MDS with multiple different types of cells that look funny versus MDS with rising blast count. And really how the pathologists grade this is by looking at the number of cell lines. So the whites, reds, or platelets, those are kind of the three cell lines. How many of those lines look funny or are dysplastic. And then they look at the cytopenias. So are there low counts in all of those cell lines, reds, whites, and platelets, or is it just one or two? Then they look at the blast cells. Remember that myeloblast picture I showed you? So they look to see if those are greater than 5%, 10%, 19%. And then they look at the chromosomes, and they put all of that information together to give it a name. But that's what it looks like under the microscope. So when you're seeing your doc in clinic, how do they figure out what the best treatment is? And they use this risk stratification, this prognostic scoring system, to help guide suggestions for what to do for treatment. And this is called the revised IPSS, or International Prognostic Scoring System. This was published back in 2012, and it was an updated version of the original scoring system that was published in 1997. And what this scoring system does is it looks at the cytogenetics, or the chromosomes within those bone marrow cells. It looks at the percentage of blast cells in the bone marrow. It looks at what the hemoglobin is, what the platelets are, and what the neutrophils are. And it gives us this very easy scoring system that can easily be done quickly in a clinic visit. And when all of those pieces of information are put in, it ends up putting patients in categories based on all of those factors. And it gives a prediction on how people will do in the absence of treatment. So that's a very important point to take home. These are outcomes if no treatment is undertaken. And basically you can see here that if you're in the very low or low risk category, people can do well for 10, 12 years without any intervention. So that's the group of people that you'd say, yeah, I think we should just monitor things, because our treatment isn't going to improve much on this. Whereas folks who have higher, very high risk MDS, you can see that if no treatment is undertaken, the outcome doesn't look so great. And so this is the group of people we say, look, we got to do something from the get-go because we want to change this curve. And that's the whole point of this scoring system when people are first diagnosed. This scoring system looks at chromosomes. We talked a little bit about chromosomes earlier. And what can happen in MDS is that the chromosomes can be altered in that bone marrow. And there are very characteristic changes that can happen. And this is probably why the MDS develops. A chromosome change happens, and then the bone marrow doesn't work right. And there are numerous different abnormalities we can see. And depending on what those abnormalities are in the bone marrow, that really impacts survival as well. So if you have a good risk chromosome change, again, people do quite well without any intervention. But if you have a higher risk chromosome change, then we need to do something because we want to change this survival. We can also see that there are differences in how people do based on their age. As I told you before, this is not a common cancer to have in people who are under the age of 50 or 60, but it does happen. And as you can see here, the outcomes are a little bit different. So if you're younger than the age of 60 and you have very low or intermediate risk MDS, you can see that most people are still doing great out to 10 to 12 years. But if you're over the age of 60, even the low and very low risk folks, their survival is a little bit different. And that could be from a whole host of factors. But this part also plays into treatment choices. So the next way we look at things is something called molecular classification. And this is really a newer method of classification. And what do I mean by molecular analysis? So here's a little schematic of how things break down in the bone marrow. So every cell in our body, whether it's a heart cell, a lung cell, a bone marrow cell, has this thing in it called a nucleus. And inside the nucleus are chromosomes. And these chromosomes are made up of DNA. And what we can see in MDS are basically that you can be missing parts of a chromosome, or chromosomes may look normal, but if you get down to the DNA level, you can find mutations in that DNA. And back in 2011, Behar et al. Published this paper where they looked at a number of patients with MDS and found all of these basically letter soup of different mutations that can happen. And the important point isn't to memorize what these numbers are, but just to know that if we see specific mutations in that DNA, then that impacts how people do. And what they further looked at was how that kind of went together with that prognostic scoring system. And basically the point of this slide is to show that whatever score you get in that IPSS, if you have one of these mutations, it bumps your score up. And so this is a lot of detail, a lot of naming, a lot of risk stratifying, and you're probably thinking to yourself, why is all of this needed? Well, there are very different clinical outcomes depending on the type and the characteristics of this MDS. As you can see, people can do well for 10, 12 years without any intervention, whereas other folks have disease that it looks a little bit more explosive and can progress to acute leukemia. And until recently, we really only had supportive therapies. But now there are treatments ranging from those that can control the disease to those that can cure the disease. And so for patients with higher risk disease, we want to be aggressive and offer curative therapy if that fits with what patients want. But if the MDS is not that aggressive, then we don't want to hurt people or put people at risk for complications or side effects from a treatment that's not needed. So really, it's a balance of figuring out how risky is the MDS and how risky is the treatment. So in order to talk about treatment options, we need to, again, look at what patient treatment goals are and then what the risk stratification is. So in terms of higher risk MDS, which is the main focus of the talk for today, we'll talk about some treatment options. And the treatment options really start with those that can control the MDS. They're not curative, but can hopefully improve quality of life, alter the risk of progression to acute leukemia. And the two drugs that fit this classification are azacitidine and decitabine. Azacitidine was FDA approved in May of 2004, and decitabine followed in May of 2006. We have clinical trials for patients who may be treated with hypomethylating agents and then progress. And then there's treatment to cure the MDS, and that's the stem cell transplant. So in terms of hypomethylating agents, azacitidine or decitabine, these were really the first, what we call disease-modifying non-transplant therapies. And what does that mean? It means that we push that curve out. I showed you curves of how people do in the absence of treatment. Well, azacitidine and decitabine were the first to actually change that curve. And what they found in these early studies was that it improved quality of life, and it really changed that chance of progression to acute leukemia. But these drugs are a little bit different than standard chemotherapy. If you think about standard chemotherapy, I kind of describe it as the atomic bomb chemo. It gets in there and it just kind of wipes out everything that's growing fast. And that's why people lose their hair and may have a lot of nausea and other issues. Hypomethylating agents are a little bit more slower acting. They're kind of like the stealth fighters that get in there and try to fix some of those abnormalities in the DNA. And because it's this stealth fighter, it's a little bit slower acting. So it can take a few months to see a response. And the goal is really to fix the abnormalities in those bone marrow cells that cause the MDS. And if that happens, then you start to see improved blood counts and decreased transfusion needs and decreased risk for infection. Once this therapy starts working, we typically consider it a chronic therapy. So once we see a response, you keep doing it as long as it's helping and not hurting. So the benefits of this are that it's well tolerated, even in older patients with other medical issues. It's outpatient treatment. It improves survival, delays transformation to acute leukemia, improves quality of life. And the responses are seen even in the higher risk groups, those with high risk bone marrow chromosome changes. The drawbacks are it can take months to see a response. So it requires a lot of patience on both the doctor and the patient side to allow the chance to see if that response is going to happen. It's chronic therapy. So again, you continue this monthly as long as there's a benefit and minimal toxicity. And the drawback is it's not a cure. At some point, it will stop working. So what about stem cell transplant? This is the one potentially curative therapy that we have for myelodysplastic syndrome. But before we jump into transplant details, we first kind of need to understand a bunch of things about it. So first things first, what is a stem cell? If you remember back to that picture I showed you in the beginning, it is the cell in the bone marrow that makes all of the rest of your blood cells. It's that mother cell. And this is really the cell that's messed up in MDS so that normal blood cells are not made and transfusions are needed. So what is a stem cell transplant? Really, it's a two-step process. The first is conditioning using chemotherapy and or radiation to basically get rid of the MDS cells in the bone marrow and make room for the new stem cells to grow and replenish the blood supply. I think of this as the weed killer part. The MDS cells are a bunch of weeds in the bone marrow, and we want to kill off the weeds, so we use the weed killer. And then the transplant is the infusion of the donor stem cells via IV in the blood, and they make the trip from the bone marrow down, or from the blood down to the bone marrow to start producing the blood cells. So this is the planting of the seeds. So how is the stem cell transplant a possible cure? Well, there are two ways that a transplant works. The first is that conditioning given before the stem cell infusion decreases the amount of MDS in the body. This is actually likely the less important part of the process. Then the new stem cells come in, and not only do they create red cells and white cells and platelets, but they make a whole new immune system. And this new immune system then is what recognizes any remaining MDS cells that are left behind and kind of zaps them and gets rid of them. So why don't we do stem cell transplants for everyone? It sounds pretty straightforward, right? Well, not everyone has a donor. Not everyone is fit enough to undergo the treatment due to other medical problems. And it's not a guaranteed cure. So cure rates range anywhere from 30 to 70%, depending on the type of MDS, the MDS chromosome and molecular changes, and the status of the MDS at transplant. And there are potential risks for transplant that are higher than other therapies. So in terms of side effects, infection risk is pretty substantial in that first year or so after transplant. People can have organ damage from the chemo, from the anti-rejection medications, or the antibiotics that are used to protect against infection. People can develop this thing called graft versus host disease, which is basically the new immune system attacking the patient. not just the MDS cells left behind, but the patient or the recipient of the transplant. And life-threatening complications can occur. So the risk of dying ranges anywhere from 15 to 30%, depending on the type of transplant and the patient fitness. So then you're probably thinking, if the risks are that high, why do we even consider transplant? Well, we really want to balance that risk of the MDS with the risk of the treatment. And if the risk of a life-threatening or life-altering complication due to the MDS is higher than the risk of the transplant, then it definitely makes sense to consider the transplant. So how do we make that assessment? Again, we go back to that revised IPSS, that scoring system that we discussed in the beginning. And this is why these risk scoring systems are so very important. So once we've decided that a stem cell transplant makes sense, we have to find a stem cell donor. So we can use a brother or sister, that's called the sibling transplant. We can use an unrelated adult donor through the National Merit Donor Registry Program. We can use umbilical cord blood. And now there's actually a big use of haploidentical or half-match transplants. We do a clinical evaluation to see if the patient is fit enough to proceed. So we look at heart function, liver function, lung function, kidney function. And once that all checks out and the MDS is in a good status to move ahead, then the transplant happens. And that is usually a hospital stay of 3 to 6 weeks, depending on the conditioning type, where they get the conditioning chemotherapy, the transplant infusion. And basically, we monitor for count recovery and for complications. Once people get out of the hospital, they go to the bone marrow transplant clinic where there's close follow-up. And we classify it as a cure if people are still in a remission at 2 years post-transplant. So now the big question is, to transplant or not to transplant? That is the question. And is one better than the other? Well, that question was recently asked and answered in a national randomized clinical trial comparing transplant and azacitidine or hypomethylating agents in high-risk patients with MDS. And this was called CTN 1102, or the Clinical Trials Network 1102. The co-chairs of this were Dr. Cutler and Dr. Nakamura. And it was a multi-center biologic assignment trial comparing reduced intensity transplant to hypomethylating therapy or best supportive care in patients with advanced MDS age 50 to 75. And I'm presenting the results that were actually just published in the Journal of Clinical Oncology. And the type of study this was called a biologic assignment study. So what does that mean? Basically, patients who were age 50 to 75, who were fit enough to get a transplant, who had higher risk MDS, were assigned to either get a transplant or not based on whether or not they had a donor. So for patients who had a brother or sister or who had an adult unrelated donor through the National Merit Donor Program, went on to go to the transplant arm or the donor arm. And patients who did not have a suitable donor went on to the no donor arm, where they got either best supportive care or hypomethylating agents, azacitidine or decitabine. And the whole point of this study was to see if survival was better with transplant versus without transplant. The next part of the study, or the endpoints that were looked at, were whether or not people were alive and free of the MDS, and if quality of life was better in folks who had a transplant or not. And then also, what about cost? Because all of this treatment is expensive. And what you can see here in this figure is, in the dark line are the folks who went on to a transplant, and the yellow line is folks who had hypomethylating agents. And what you can see is that people did better if they had a transplant. And on the slide here on the right, they looked at different characteristics of patients undergoing the transplant. They looked at age, they looked at how long the MDS had been present, they looked at the risk scoring system, whether or not they had been treated before or not. And actually, every subcategory that they looked at did better with transplant compared to not transplant. They also looked at quality of life, because obviously quality of life is a big deal. You don't want to go through a process that's incredibly intense and overwhelming and feel worse even if your MDS is better and you feel worse, that's not a great outcome. So this study really wanted to focus on how folks lived with the treatment and what their quality of life was. And these are just a number of different scoring systems that they looked at, looking at quality of life. The whole point to focus on is that donor here in purple versus no donor arm in yellow, it was really quite similar across the board. So people had a similar quality of life that they did transplant versus not transplant. So what are the implications to clinical practice based on this? Well, I would suggest that if you look at this data, folks with higher risk MDS, age 50 to 75, do better with the transplant. So we should be considering transplant early on in folks who are diagnosed with MDS. And if we're considering transplant, then we need to make early referrals to transplant centers. The BMT-CTN, or the Blood and Marrow Transplant Clinical Trials Network group, has created different working groups to help try to put all of this new information out into practice, try to disseminate this information. And I had the privilege of being co-chair of the BMT-CTN 1102 Evidence in Practice Working Group. And basically all that meant is we looked at this study and we tried to figure out how we can disseminate the information and expand things so that more patients with MDS can be referred for transplant. And in order to figure out how to expand things, you kind of need to figure out who are all the major stakeholders, or who are all the major players within transplant care for patients with MDS. And we need to get everyone on board so that we can get transplant out to more MDS patients. And so this is a nice pictorial of kind of all those stakeholders. Obviously, patients and caregivers are in the center of it all. But then a lot of other components need to be in place. So we need payers or insurance companies, including Medicare, to understand that transplant is effective for patients with MDS and give good coverage. We need patient advocacy groups like the MDS Foundation to help get this information out to patients. We need community oncology practice groups to be involved to know this information so that they can make the referrals. We need the transplant centers, obviously, to be involved so that we have enough people. We have enough doctors and nurses and pharmacists and social workers and hospital beds to perform the transplant centers or transplants. And then we need the National Marrow Donor Program to help with the donor searches. So in order to think about expanding that whole network, we kind of need to think about each individual piece and what are some of those barriers or challenges, and then what are the paths we need to go down to expand this access. So obviously we need all the stakeholders, everyone involved and on the same understanding that transplant is effective for patients with MDS, and payers are willing to pay for it. We need to get timely referrals to transplant consultation, which means that we need to get all the study results out. So starting with talks like this, where we let patients know how much transplant can impact their care. We need to have outreach by the transplant centers to the local oncologist to let them know which patients are appropriate to send for transplant evaluations. And then we need to expand the access to referrals. And COVID has done amazing things in terms of expanding the options for video consults and telehealth consults. So that's a great way that we can do a lot of these consults with people who don't live in the metro area, and save them the travel time, expense, et cetera, of coming numerous hours for a visit. We need to expand the healthcare system. So we need to have enough doctors, nurses, social workers, pharmacists to care for all the patients. We need to develop the infrastructure. We need to improve the care delivery model so that, if people are moving to come to a transplant center, we care for them there, but then we get them back to their local oncologist and have good communication between the two. We need to figure out costs. So all of these treatments are expensive, transplant and non-transplant. And one of the things that this study is looking at is a cost care analysis comparison between the two. We need to standardize insurance benefits so that all patients with all different types of insurance can have the same good coverage for for transplant. And we need to work with Medicare to get better Medicare reimbursement. The most important thing, though, is for patients and caregivers. Obviously, the patient is the one going through all of this. And it's a big deal. So we need to address all the emotional needs of the patients and the caregivers. For people who are moving across the country or moving across state lines, we need to address housing needs, financial support, and really having a point person that's a patient navigator at the transplant center is another important component, I think, of making this work well. The other thing is we need to look at racial disparities. So when we look at who gets MDS, it's not just a white bone marrow cancer. It affects all people, African Americans, Pacific Islanders, Hispanic folks, and white people. But if you look at the studies, the majority of the people studied are white. So we need to figure out why that is, that not all people are being referred for transplant. Are there biologic or systemic factor that leads to these disparities? We need to improve the diversity of the workforce so that all patients can have providers taking care of them that look like them. And we really need to strengthen the data collection and research regarding this. And additionally, we need to grow the donor pool and diversify the donor pool so that all patients have a potential donor. So that was a lot of information to cover. But in summary, MDS is a very complicated blood cell factory disorder that can range from a mild form to an aggressive acute leukemia type illness. And treatment decision-making depends on the severity and the symptoms. And the decision to treat or not to treat really depends on what's causing more symptoms. Is it the MDS or the potential treatment? And then the treatment choice depends on the age of the patient, risk scores, chromosome changes, the fitness of the patient, and the patient treatment goals. Curative therapy exists with stem cell transplant, and due to the improved survival that we see with this recent study, we should consider transplant for all high-risk MDS patients who are medically eligible and are interested in curative therapy. And we need to continue to work to educate patients about all treatment options, to partner with referring oncologists to facilitate easier transplant consultations, and improve the infrastructure to expand transplant options to more patients with MDS. So I will stop there and open it up for questions.
Thank you, Dr. Warlick, for your wonderful and very thorough presentation. And thank you all for joining us today. For those who haven't sent in your questions, you can start submitting your questions in the question box found on the bottom menu bar. We don't want you to leave today without getting your questions answered. And for those who want to revisit this recorded webinar, a viewing link will be sent to all registrants and will be available on the MDS Foundation website for on-demand viewing within 10 business days. All right, let's proceed to the live Q&A. Our first question is, assuming all options have been exhausted, including clinical trials, and the choice is transfusions every 2 weeks or stem cell transplant for a healthy 75-year-old in excellent physical condition and no blasts, which choice would make the best sense?
That's a great question. I am presuming that person has gone through hypomethylating agents and is still requiring transfusions. It really comes down to a personal choice. I mean, I've had some 78-year-olds who are incredibly fit, who have gone through the treatments and they haven't worked, and they don't want to transition simply to transfusions, and they've asked about transplant. So I think it really comes down to the patient's goals and the patient's level of fitness, and really weighing that risk-benefit ratio. I mean, obviously, transplant, as I talked about in my presentation, is not easy. It's not straightforward. And yes, some people go through it without any major bumps and complications, but other people have a lot of complications. So I think it comes down to that individual. Are they willing to risk those potential complications for the possible benefit of cure and then not needing transfusions? So I think for a very fit 75-year-old who is open to those potential risks for a big potential benefit, then a transplant really does make sense.
Thank you, Dr. Warlick. The next question is, if a patient is diagnosed with MDS and their healthcare provider hasn't classified this, is this normal? Should they see a different provider? When they've asked what their subtype and risk score are, the provider has told them we don't use that prognostic scale.
I guess I, as a patient, if I were in that situation, I would want to see the biopsy report. I mean, sometimes when people get a bone marrow biopsy and there's a question that it could be MDS, the pathologist will sometimes say, findings suggestive of, but not diagnostic of MDS. So that could be the situation that this patient and provider are dealing with. But if there is a diagnosis of definitive MDS, then they typically can classify it. And if it's not, excess blast 1, excess blast 2, sometimes it is MDS not otherwise specified. But if it is a true diagnosis of MDS, then a risk scoring system can be employed, and that calculation should be there. So I guess I would encourage the patient to ask to see the pathology report. And if it says suspicious of MDS, then yes, I would agree that you can't really give a prognostic scoring system if it's not definitive MDS. But if it is definitive MDS, then, and they're not getting those answers from their current provider, then I think it's always good to get a second opinion. I mean, I don't have any issues with my patients going to get a second opinion because, MDS is a challenging blood cancer to deal with. And as a patient, you want to make sure that you know exactly what you have and what you're dealing with. And sometimes it's helpful just to hear the description of what you have from different providers, because we all describe it in a different way. And so I would encourage that person, if there still are questions, definitely get an additional opinion, because the more information and data you have coming in, the more you can deal with your medical issues.
Thank you, Dr. Warlick. Great answer. The next question comes from Randall. He wants to know, what is the role of Venetoclax in high-risk patients who are not a transplant candidate?
That's a great question. And I think as MDS docs, we're still trying to figure that out. So Venetoclax is an awesome new, well, it's not incredibly new, but it's new for the myeloid malignancy sphere. It was FDA approved to treat older, untreated AML, newly diagnosed acute myeloid leukemia, a couple of years ago in combination with either azacitidine, decitabine, or cytarabine. And it has revolutionized the care of older AML patients. In fact, I've had patients on it who've done well for a couple of years with incredibly good quality of life. So that's how it has been studied in AML. It is really still new in MDS. So a couple of years ago at ASH, the American Society of Hematology meeting, actually a year and a half ago, was the first time they presented some data on the use in MDS. And it's continuing to be studied. I'd say I've seen a lot of private practice groups start using it in higher risk MDS. I have not used it upfront so much in high risk MDS because I think we're still learning how it works with MDS. I have used it in some of my patients who have not responded to azacitidine or decitabine. And what I've seen is that it definitely acts differently in an MDS bone marrow versus an acute leukemia bone marrow. It seems to work incredibly well against those blast cells. How the rest of the MDS marrow responds to it is a little bit more perplexing. So I've had some patients who've had an awesome response with the blast going down, but then it seems to really suppress the rest of their marrow. And I've seen it require multiple months of transfusion needs and support until the marrow kind of recovers. So I think we're still learning about its use in MDS. Like I said, there have only been phase 1, so early studies in MDS with the combination Venetoclax and azacitidine. And so I want to see a little bit more data before I think we use it more consistently in higher risk MDS.
Thank you. The next question is, how does the mutation TP53 affect the outcomes of hematopoietic stem cell transplant?
That's an awesome question. So the TP53 mutation is definitely one of those mutations that's higher risk. And by higher risk, it means that it's harder to, I'd say, control it, and definitely harder to cure it with transplant. So there was a study a handful of years ago called 0901, another clinical trials network bone marrow transplant study, where they looked at acute myeloid leukemia patients and MDS patients who had achieved a good response and went on to transplant. And it was comparing what's called the myeloablative conditioning, where we wipe out the entire marrow, versus the reduced intensity conditioning, where we wipe out about 80% of the marrow before the transplant. And that study actually showed that the myeloablative tended to have better outcomes. So they did subsequent analysis looking at the mutations, and definitely did find that folks who had the P53 mutations had a lower chance of cure. But that being said, if they went into the transplant with that mutation not detectable, the outcomes were actually pretty comparable. So that mutation is definitely a tougher one to treat. It doesn't respond as well to kind of old school conventional chemotherapy. It tends to respond a little bit better to more novel agents. And if you can get that mutation as low as possible, the burden of that mutation as low as possible, or even undetectable before the transplant, then the chance of better outcomes with the transplant are there.
Thank you. The next question comes from Denise. She would like you to discuss haploidentical transplant a little, and should she keep looking for a better non-related match instead?
So that's a great question too. There are a lot of different donor options. A sibling donor is our first choice. Adult unrelated donor used to be kind of the second choice. And I'd say still is in some situations. But then the alternative donor options are the haploidentical, which is a half match, versus umbilical cord blood. And those were actually studied recently in a randomized head-to-head study. The results aren't formally out as of yet. But I've had a number of patients go through haploidentical transplants. I have some from when I was a fellow in 2005 who are still doing great in a remission, 16 years later. So it's a great option. I think it comes down to what are the other donor options there. And if there's a fully matched unrelated donor option, I do think that one probably makes sense because it's fully matched. And we don't really have a head-to-head comparison of fully matched versus haploidentical transplants. But if it's a mismatch unrelated donor versus the haplo, then I think it's probably comparable. And some of it comes down to the urgency of the transplant, the donor availability and timeline to get there. And so I would encourage, that patient to really talk through the details of the specific donor options with their doc. And their doc should be able to describe the pros and cons of each, and come to a joint decision on what's the best option.
Thank you. The next question comes from Natalie. It's a Medicare question, so I'm not sure, Dr. Warlick, if you can weigh in on this or not, but she wants to know, what is the Medicare reimbursement for stem cell transplant?
I have no idea what the actual Medicare reimbursement is. I do know that, probably about 10 years ago, Medicare did not want to cover transplants for MDS. They would allow coverage if it progressed to AML. And then there was a lot of work done, actually doing a big kind of prospective study, looking at the benefit of transplant for MDS in Medicare age individuals. So they now cover it. The amount of coverage, I don't exactly know. I mean, the majority of the patients that I have taken care of going through transplant are Medicare age patients. And they've honestly never described a lot of medical hardship. I mean, I think the coverage has been pretty good. I know a lot of them have supplemental insurance that will often pick up some of the additional costs. So I think that's the best I can do. Sorry, I can't give more specifics.
Thank you. That was very helpful. The next question comes from James. He would like to know a little bit more about exactly what is a haplo partial transplant.
Sure. So when we look at finding a donor, we look at something called HLA testing, which is kind of like your immune system fingerprint. And you get half of this HLA type from your mom and half from your dad. So by definition, that combination, to find the best match, you need to have a brother or sister. So if you have two brothers or two sisters and they got different shuffling of those systems, then they will be a half match. Other half matches are basically your children. So again, you're passing on half of your HLA type system and your significant other is passing on the other type of their HLA. And it's just a combination of that mixing. So it's really a half match of that mixing of HLA typing. I don't know if that described it very well. The difference and why this is a little bit more experimental is that if you think about, when you're giving someone a new immune system, a fully matched immune system is one that's going to recognize the recipient of that transplant as less foreign. So the concern when you do a half match is that there is more of a difference in that new immune system and the recipient of that transplant. Where we got around that kind of difference in that level of foreignness between the new immune system and the recipient is with a technique called high-dose cyclophosphamide. And this was actually really developed at Johns Hopkins, and I got to see a lot of it when I was there as a fellow. Basically, what the approach is when you get the stem cell transplant, within that transplant are these things called T cells. And it's those T cells that really are the immune surveillance that help get rid of the remaining MDS and keep the MDS in check. But those immune cells, those T cells, can be very reactive against the recipient. And what we have seen is that the cells, those T cells that are really reactive, start to grow and divide and start to want to attack around day 3 and 4 after the cells go in. So what the Hopkins researchers found or studied is basically giving this chemo drug called Cytoxan on days 3 and 4 kills off those really reactive T cells that can cause the graft versus host disease, the immune attack of the donor against the recipient, and then allow that half-match transplant to kind of take effect. And the cool thing about this Cytoxan drug is that it really only gets those T cells. The stem cells that were just transplanted actually have an enzyme in them that inactivates the Cytoxan. So those transplanted stem cells are safe from that Cytoxan, but it really just kills the very reactive T cells and diminishes that risk of immune attack of the transplant against the recipient. So that's really what has allowed the half-match transplant to expand and be more of a possibility for patients. So I hope that answers the question.
Thank you. The next question comes from Julie. She wants to know if there is a difference between a stem cell transplant and a bone marrow transplant.
Great question. Yes and no. So the thing that we're always transplanting are stem cells. These stem cells come from the bone marrow. How it gets the term bone marrow transplant or peripheral blood stem cell transplant just comes down to how do we collect the stem cells from the donor. If we take the donor to the operating room and extract the stem cells literally from the bone marrow, we call it a bone marrow stem cell transplant. If the donor gets hooked up to a machine called an apheresis machine and we collect the stem cells out of the peripheral blood, then we call it a peripheral blood stem cell transplant. So the transplant is always a hematopoietic stem cell transplant, and whether it's named bone marrow or peripheral blood just depends on where we get the stem cells from.
Thank you. Natalie has a question. Is it recommended to do both azacitidine and decitabine simultaneously. I'm not sure if she's asking if it's a bridge to transplant or just as a treatment option.
So the azacitidine and the decitabine are kind of sister drugs. They work the same way. So you don't give them together, you just give one or the other. And either of those could be a bridge to transplant, but either of those could be a treatment in and of themselves. So if I have an 80-year-old patient that I'm not going to bring to transplant who needs treatment, then I would pick either the azacitidine or the decitabine. If I have a 45-year-old or a 50-year-old patient who has transfusion needs and has higher blast percentage, then we would talk through, which drug we were going to pick, either the azacitidine or the decitabine, to get them and their bone marrow in a good status and then move on to transplant. So either one can be used by itself or as a bridge to transplant.
Thank you, Dr. Warlick. The next question is, are autoimmune disease patients at higher risk of failure with stem cell transplants for MDS?
That is a good question. And I'm presuming it's like other autoimmune diseases like Crohn's disease or MS or rheumatoid arthritis. I don't know that they're at a risk for failure to the transplant. I mean, what I have seen with some of my patients who have had other autoimmune diseases and then developed MDS and went on to transplant is that their other autoimmune disease got better. So I had a patient who had Crohn's disease and that actually kind of went away with the transplant. I had another patient with MS who that got better as well. Where it could potentially pose a problem is sometimes patients will have received other treatment for their autoimmune disease. And then the MDS they get can be a secondary or a therapy-related MDS that has more of those high-risk mutations, like the P53. And then the MDS can be a little bit tougher to cure or treat. But those are kind of the main complications or complicating features that I can see with an autoimmune disease.
Thank you, Dr. Warlick. The next question comes from Neil. He is 91 years young with MDS for 12 years. And his oncologist says that an early complication rules out the application of the standard classification system, but it's certain based on biopsies that he does have MDS. He's watching weight. He's not taking any MDS medications. The only symptom he has right now is fatigue. He's walking slower. So he wants to know, is transplant an option for him?
So at the University of Minnesota, our upper limit of transplant was 75. So I think he's a little bit out of that window. But that being said, I honestly, regardless of the age, if he's had it for 12 years and the only symptom is fatigue and he's on an observation, watch and wait, the MDS is not causing, at least from that description, it's not causing severe enough issues that warrant the risk of a transplant. And I would argue that if it's been stable for 12 years, that's a good sign that it's going to be stable for a number of years going forward. And even if you were 71 as opposed to 91, not needing transfusions under observation, I wouldn't recommend a transplant to my family, and I definitely wouldn't do one for myself if I were in that situation. So hopefully that helps.
Thank you, Dr. Warlick. Phil is in full remission, but he's still under treatment with azacitidine every 4 weeks. Should he consider transplant? Or his second question was, should he lengthen treatment interval or should he stop treatment altogether?
So great questions. So and I'm going to answer it in a couple of different ways. So if I have a patient that we've said we're not doing transplant, that the goal is to control the MDS, have a good quality of life for as long as possible, and azacitidine was indicated, then once a remission is achieved, we typically keep doing that azacitidine as long as it's helping and not hurting. So if the goal is good quality of life, control the MDS for as long as possible, then I would continue the azacitidine. But I have a number of patients who, they're doing great, their counts are great, and the every 4 weeks is getting a little bit cumbersome. So I will sometimes slowly push out that interval, to 5 weeks, make sure things stay stable at that, push it out to 6 weeks, make sure things stay stable at that. And then, that decision about whether to keep pushing it out really depends, is really a personal decision with the patient and their doc. If the goal is a cure and the azacitidine has got you in a remission, then now would be the best time to go to transplant. So I think it really depends on, again, what the goals of care are, and then having that dialogue with your doc about next steps.
Thank you. The next question comes from Natalie. If an MDS patient has a haploid match for stem cell transplant, are their outcomes as good as a full match donor? Does the doctors Cutler and Nakamura research address the different transplant matches outcomes?
Good question. So the study that I presented actually looked at unrelated and related donors, fully matched transplant. So it did not address the question with haploidentical or cord blood, and that definitely will need to be looked at as well. There's not a head-to-head comparison of a fully matched and a haplo. So if someone does have a fully matched option, that's what we would recommend using. If they don't have a fully matched option, then the haploidentical is a great next choice.
Great, thank you. Marion wants to know, is she correct in understanding that if you have a TP53 mutation, at its present, will you still have the mutation after transplant?
Oh, the goal is that it goes away. So, the hope is that the hope is actually going into the transplant in a remission where we can't detect that mutation. But if that's not the case, then once we give new stem cells, the goal is that all the old MDS cells that had that mutation present are now gone. So the goal is for that mutation to go away.
Thank you. Phil wants to know, how does the DNMT3A mutation affect MDS progress?
So it is one of those mutations that puts you at a little bit higher risk. But that being said, it's not one of the high risk like the P53. People with that mutation often actually respond pretty well to the azacitidine or decitabine treatments. So that's one good feature. But it's another way to describe the MDS. And then the hope would be if you get into a remission with either the azacitidine, decitabine, or a transplant, that mutation then goes away.
Thank you. We're getting a lot of compliments for you, Dr. Warlick. I just wanted to let you know they're weighing in that your information is very informative, easy to understand, and they're expressing their appreciation. So I just wanted to let you know that. The next question comes from Denise. Is there a difference in outcomes between fully matched related and fully matched unrelated donors?
So we have looked at that. We've looked at that at the university with AML and MDS, and it looks like things are relatively similar. So where the subtle differences are, we talked a little bit about that HLA matching that you get from your mom and your dad. We can only test that HLA typing to a certain level of specificity. So we know that if you get half from your mom and half from your dad, the more subtle things that we can't test for are likely similar. That's a little bit different to an unrelated donor. Again, we can test for those things that we can test for and find that they're similar, but the subtle things that are below the level of detection are likely going to be different with an unrelated full match than with a related full match. And that's where we may see a little bit more in that risk of graft versus host disease. And again, graft versus host disease is the new immune system attacking the recipient of that transplant. But that being said, we have numerous new approaches to deal with the graft versus host disease. One is that post-transplant Cytoxan that I talked about, and a lot of new oral drugs that there are these rejection drugs. And so I think we're getting better at dealing with that complication. So the outcomes with a matched related and a matched unrelated are starting to get closer. And I'd say they're not that far off from each other.
Thank you. Nancy was just diagnosed and she lives 2 to 3 hours from the transplant site. Are there any uniform guidelines about proximity to transplant sites and any other guidelines?
Yep, so great question. Typically, if people live outside of about a 30 to 45 minute driving distance from the transplant center, we will require patients to kind of relocate to the transplant center area up to about 100 days after the transplant. So in Minnesota, we have people coming from North Dakota, people coming from Iowa, people coming from kind of outstate Minnesota, and they'll relocate and get an apartment. Or before COVID, people could stay at a place called the Hope Lodge for free. It would basically just relocate here through the transplant with their caregiver and then to day 100. So those are pretty kind of standard guidelines for all transplant centers. It's tough, it's a big move, and it's, a good 3 to 4 months that you're away from your home and the bulk of your support system. So that's a big ask.
Thank you. Nancy also wanted to know, she's been on bone marrow transplant sites, and some of them include survivorship programs and some don't. And she wants to know, what are those differences?
The majority of transplant centers have a survivorship program, even if it's not kind of listed on their site. After a transplant, we have patients come back, even when they go back to their local oncologist. We'll have patients come back for their, what we call them, anniversary visits. So people will stay through day 100. We have them come back at 6 months, at a year, typically a year and a half and 2 years after the transplant. And at the university, we've built in kind of survivorship components that we look at each of those visits. And the big things we're looking at are, long-term effects from the transplant. We're making sure people get all their immunizations, so they're revaccinated. We make sure people don't have long-term heart and lung issues. We make sure people's thyroids are intact and their cholesterol is intact. So it's kind of like a souped up primary care health maintenance focus, looking for post-transplant complications and support. And some people may have a formalized survivorship program, as they call it, but all transplant centers really are looking at that health maintenance after transplant.
Thank you. The next question comes from Marion. If you are on Cytobean and can only take a half dose every 6 weeks, and she got pneumonia during treatment, would it be feasible to stop this treatment?
It's always feasible to stop the treatment. As a patient getting the treatment, you are in the driver's seat of what you're willing to endure. And how I always approach it with patients is I really look at kind of the cost and benefit. So are people having, infections and needing more transfusions and coming to clinic to get transfusions 3 to 5 days a week, or are they doing okay with it? And it's really looking at the complications. And again, going back to complications of treatment versus complications of MDS. The goal is for people to be able to live well without a huge number of complications. So if the treatment is leading to more transfusions and infections, and it's not controlling the MDS, then it makes sense to stop. But even if it's controlling the MDS and keeping blast down, but it's tying a patient to the clinic and admissions to the hospital and infections, then it may not make sense. So I think it's really, I have people make lists, what are the benefits that they're seeing and what are the drawbacks? And then the doc should be looking at that too. And then you sit down and talk through what those risk benefits are. And if the risks are adding up and the benefits are low, then yeah, it makes sense to take a break. And sometimes that's how I'll approach it. I'll say, you know what, let's just take a break. Let's give you 2 months of seeing how you do off treatment, seeing if those infections get better, seeing if those transfusion needs improve, and then we readdress. So it's not a major decision that if you want to take a break, it's done, that's it, you're making this monumental decision. It's saying, no, let's just pause and let's see how you do off of it for a month. And that may be a good happy medium approach for this patient.
Thank you. Randall wants to know, what is your preferred method of treatment for iron overload after transplant? Do you recommend oral or IV chelation?
So after transplant, it's a very different question than before transplant or with chronic therapy. So after transplant, the hope is actually that your blood counts are normal and you're not needing transfusions. So if your hemoglobin is normal and you're not needing transfusions, then the best way, honestly, to get rid of the iron is with something called phlebotomy, where you take off units of blood every couple of weeks, let the bone marrow recover and get the iron off that way. And that's actually a quicker way to do it. If that's not the case, say you're post-transplant, but you're still needing red cell transfusions and you're iron overloaded, then the decision-making actually comes down to what the platelet count is. So if the platelets are normal, then you can use some of the oral iron chelating drugs. If the platelets are low, then the best option is an IV infusion called Desferal. So there are kind of a lot of caveats of my decision-making process based on the post-transplant outcomes. If patients are undergoing therapy, they haven't had a transplant and they're still needing transfusions, but their platelets are good, then I typically would try the oral. If their platelets are not good, then we would do the IV.
Thank you. Dr. Nita wanted to ask, how frequently do you encounter drug-induced cytopenias post-Cytobean, and how do you manage them when you have to proceed for the next cycle?
So that is where it's the art of treating and not the science. So everybody is different. When we're doing the decitabine treatment or the azacitidine treatment, I usually look at what the blood counts are pre the first cycle. So, the platelet count, the neutrophil count, the hemoglobin. And my goal for the start of the next cycle is to get to at least what that baseline starting point was. And then the hope is over time, that baseline starting point continues to rise and the counts get up to normal. If, say, the count started at a certain level, we do one cycle, and at 4 weeks, they're not back to that level, then I wait a week. If they're still not back to that level, then I wait 1 more week. And if they're still not back to that level, then I actually repeat a bone marrow biopsy. Because the question in my mind at that point is, are the counts low because the chemo suppressed the good cells in the bone marrow and suppressed that count recovery? That's called myelosuppression or cytopenias from the chemo. Or is the MDS progressing? Because if the MDS is progressing, we want to push ahead with the next cycle. If it's suppression of the bone marrow from the chemo, then we want to dose adjust. And the only way to really know that when the counts are low is to look at the bone marrow. And what I'm looking for in the bone marrow at that point is something called cellularity. So that's the percentage of cells versus fat in the bone marrow. And if the MDS has progressed, we'll see a hypercellular marrow. The bone marrow will be packed with those MDS type cells. But if the marrow is suppressed from the chemo, then we'll see typically what's called the hypocellular marrow. And then that will allow the doc to know, okay, yep, we need to dose adjust for the next cycle, or nope, we need to push ahead with full dose.
Thank you. The next question is, would you perform a second transplant if the relapse occurred in less than a year? And how common are relapses?
Great questions. So on average, there's about a 30% chance of relapse with a stem cell transplant. Now, that percentage goes up or down based on the status of the MDS going into the transplant, what those mutations are, what the chromosome changes are. But a 30% risk of relapse is kind of the average. Most transplants, if they're going to, or most relapses post-transplant, if they're going to happen within that first year. And then there are a few stragglers between year 1 and 2, and it's pretty rare after 2 years. I have had a handful of patients with late relapse, but they're very few and far between. So most of those relapses will happen within that first year. I'd say if the relapse happened early, like around day 100 or 4 months, then I'd be really apprehensive about doing a second transplant, because transplants really are biggest weapon against MDS and to cure it. And if a transplant or a relapse is happening that early after transplant, a second transplant probably is not going to be helpful. But say that relapse was right at a year or right before a year, then it may be reasonable to consider. The other variables that I look at also are age, other medical comorbidities, and that kind of helps me make the decision. I have had a number of patients who relapsed around 2 or 3 years, so had a good remission, but they were in their early 70s at the time of the relapse. And we went back and forth about, does it make sense to do a second transplant? And I think at that point, it was feasible to do a second transplant. And I think it would have been reasonable. But after a lot of discussion, weighing the pros and cons and the impact on quality of life, at least those 2 patients of mine decided to do more of like the maintenance therapy once they got back into a remission. So I think it depends on so many factors. Again, how soon the relapse was, what shape the person is in at that point, if they've had graft versus host disease or not, and if they're on immunosuppression, and then really just having a heart-to-heart discussion about what the hopes and the possible benefits are.
Thank you, Dr. Warlick. The next question is, if one has a genetic mutation, how does it manifest after a transplant? Meaning, does a certain genetic mutation, is it an indicator that MDS will return after transplant?
So there are a couple ways I can answer that. I guess my one question back would be, there are multiple different types of genetic mutations. There are mutations that are called germline mutations that we're actually born with, that are in all of our cells, that predispose us to developing MDS or other issues. There's one called dyskeratosis congenita that predisposes people to having head and neck cancers as well as bone marrow cancers. So the answer is a little bit different depending on if it's that germline mutation that we're born with that affects all of our cells, or if it's an acquired mutation, meaning a mutation that just comes up out of the blue in the bone marrow cells. So it's a little bit hard to answer the question in both. So if you have a germline mutation, then the hope is that with a transplant, those bone marrow cells obviously no longer have that germline mutation because there are new stem cells, but the rest of the body would. If it's a mutation that happened out of the blue in the bone marrow cells, then the hope is that that mutation goes away. In terms of risk of relapse, it comes back to a little bit of what type of mutation that was. And if it's one of those acquired mutations, if it's a P53 mutation versus another mutation.
Thank you. The next question is there an ideal donor age limit?
So with related donors, we often will go up to age 65 or 70. With unrelated donor options, I think the unrelated donor pool, it may be at 50. Obviously, you want younger stem cells if possible. So if you had a choice between a 40-year-old donor and a 70-year-old donor, you'd pick the 40-year-old donor. And part of that comes down to the fact that there are mutations that people can develop as they age that are can be seen with MDS, but are not diagnostic of MDS. So as those stem cells get older, if you remember back to my initial picture, those stem cells make all the other immune cells, plus they keep replicating themselves. So as those cells keep replicating themselves, there are the potential for mutations and different things to happen. And they're not as, I guess, spry. So the goal would be to have the youngest stem cell donor possible. If your only option was a 65-year-old related donor, then that would be a great option to go with. But if you had the choice, you would probably pick the younger of the two.
Thank you. The next question is, if you have an identical twin, is your twin your best match for transplant?
So that's a great question, and it depends on if it's literally an identical twin where the zygote kind of split in the womb, or if it's a fraternal twin. You actually wouldn't, if you had another related donor choice, you would pick the non-twin, because if you think about it, you know, if you have MDS, your immune system kind of allowed that MDS to develop. And the goal with a transplant is to give you a new immune system that can recognize those MDS cells as foreign. If you have a perfectly identical twin where the zygote split in the womb, then those immune systems are the same. And so you won't have the same immune difference recognition that you would with a sibling that's a perfect match. Hopefully that makes sense.
Thank you. So kind of on the same vein, someone's asking, if your mother is an identical twin, could your cousins be a half match?
So your cousins can still be a half match, because again, you get half from your mom and your dad. So the cousins would have a different genetic mix with the father.
The next question is from a 70-year-old male. He has a 65-year-old sister that has had 7 pregnancies. Would she be a good donor?
So the pregnancies bring up a good question or a good comment. When people have been pregnant, there is the potential of developing antibodies. So there's against the fetus. And so there's a little bit more potential immune reactivity. So when we're looking at donor options, if we have the choice between a donor that has had multiple pregnancies versus a donor who has had no pregnancies, and they're perfectly matched on all other accounts, we would pick the donor with no pregnancies, just because of that, the less immune stimulation. If it's a matched sibling, everything looks great, and that's the only option, then I still would go with that option. So it just comes down to what other options are on the table.
Thank you. The next question comes from an AML patient who is a candidate for a transplant, but does not have a family member or friend available to be their caregiver post-transplant. Would it be an option to have a paid caregiver live with them post-transplant?
Yep, absolutely. I have one patient who he went through the entire transplant process with a paid personal care attendant. Yep, so that's definitely feasible. For a lot of people, it's not feasible just from a monetary standpoint. But if money is not an issue in that regard, then absolutely. You really just need someone who can help be an extra set of eyes and ears kind of going through the post-transplant care.
Thank you, Dr. Warlick. I think we have time for one more question, and it's a post-transplant question. Can you explain maybe a little detail what the next steps are in terms of care for the patient and caregiver to follow post-transplant?
Yeah, so the post-transplant care is incredibly variable. So the biggest thing that we're looking at before patients can leave the hospital after a transplant is that they're not needing more than daily transfusions. They're taking all of their medications by mouth. They're eating and drinking okay, and fitness level is okay to be out of the hospital. And they're not having kind of newly diagnosed graft versus host disease. So once those kind of bars are met, then people can go home. And then the follow-up care is really variable. For some people, they're coming in daily for transfusions. We're making changes in the graft versus host disease medications. We're giving fluids in the clinic. Other people, their counts come in really quickly. They're not needing transfusions. So I have some patients who come in daily after they get discharged. I have some people who are quickly, spreading out their appointments to weekly. But really the caregiving is making sure that all the preventative antibiotics are being taken, the graft versus host disease prevention medications are being taken. And the role of the caregiver really is to be a second set of ears and eyes, helping to make sure those medications are being taken, helping to make sure that people are eating, getting good nutrition, getting good activity, driving back and forth to clinic, and keeping track of all those changes in the plan and the medication. And again, the amount of care and need is really dependent on how quickly those blood counts come in and what bumps along the road people have had. For patients who have had a lot of infections, had needed to go on steroids for graft versus host disease and have developed some weakness, it can be a lot of care and a lot of help. But for other folks who made it through without any infections, aren't on steroids for the graft versus host disease, they need a little bit less. And so it's really tailored to the patient and what they're going through. That is usually the case until about day 100. At day 100, we typically start tapering back those immunosuppressive medications if people don't have active graft versus host disease. And usually by day 100, people are feeling, closer to back to their normal self. And so have more energy to do the things that they want to do. If they're doing well, we, kind of release those 24-hour caregiver restrictions and people can have a little bit more freedom, get back to driving, get back to just some more independence. So again, it's really variable on the patient and the situation.
Thank you. Unfortunately, that's all the time that we have for questions. Thank you so much, Dr. Warlick, for your great presentation and your time and effort that went into preparing your webinar. Great talk. For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. If you missed out or would like to revisit this webinar, be on the lookout for an email that will provide you with the link within 10 business days. On behalf of the MDS Foundation, thank you for joining us. This concludes today's program.
Take care, everyone.